here at UNMC. Today I'll be talking about nuclear medicine instrumentation and artifacts. Today, I guess my references to start, special thanks to Dr. Neil Hansen, who first prepared these outlines and slides, so I'm really following his work here. This is based on the RSNA modules about PET-CT and SPECT-CT and gamma cameras, and there are also corresponding chapters in the Huda, Buschberg, and Mettler books. So today we're going to talk about basics of gamma camera imaging, how the device works, and how we do display and processing. We'll talk about a little bit how SPECT-CT works, well, SPECT and then also SPECT with CT, and then we'll talk about a little bit about how PET scanners, PET-CT and PET-MRI work. And with each of those, we'll talk about technical artifacts that you might see. So a gamma camera is a camera that converts photons that are emitted by a radiopharmaceutical into a light pulse, and then that turns into a voltage signal, which then gets recorded into a computer for electronic display. Most newer cameras are completely digital. Older cameras have several components. So all cameras will have a collimator, which we'll talk about in more detail on the following slides, but basically that helps eliminate scatter. They also have a scintillation crystal, which converts the radioactive, the photons from the radioisotope, converts that into light. And then you have either an array of photomultiplier tubes and amplifiers or a digital detector. Then you have a pulse height analyzer and digital circuitry. So we'll go through each of those components. To start off, this is what a gamma camera looks like in the nuclear medicine department. Usually you have two cameras, which you can either have immediately opposite each other or at a 90-degree angle to each other. And within all of those, you have all the parts. You have the collimator here, then you have the nuclear medicine, the crystal, the scintillator crystal behind that, and then you have the photomultiplier tubes and all the digital circuitry behind that. And usually they're mounted on some sort of gantry that can rotate around the patient so you can get images from any sort of angle. Here's another, just a schematic of what we were talking about in terms of how things are made. So closest to the patient will be the lead collimator, which that helps eliminate scattered radiation and only allows radiation that's going straight on to the camera to reach the next element, which is the crystal. For nuclear medicine, one of the real common crystals would be sodium iodide. And then connected to the crystal is a bunch of photomultiplier tubes, because the light that's emitted when there's a scintillation event is very faint. And so then the photomultiplier tube amplifies that and helps also determine kind of the energy and the location of where that occurred. And then you have amplifiers and positional circuitry and pulse height analyzers. All of those things help determine where the decay occurred and how strong the energy was, and then all of that gets fed into a computer that then turns it into a picture. And this is also just a similar schematic over here on the left. So first thing, the collimator is basically something made out of lead that's between the patient and the crystal. There are several different types. And the simplest type will absorb scatter radiation that's not perpendicular to the detector. So any radiation that's not coming directly out of the patient straight into the crystal gets absorbed by the lead rather than reaching the crystal. And what this does is it helps eliminate scatter. However, it does also block a lot of useful radiation, and so collimators are your rate-limiting step in terms of how much of the radiation that you injected into the patient actually reaches your detector. Here are examples of different kinds of collimators. So pinhole collimators, we'll talk about on another slide. Diverging collimators, basically, instead of having things that are exactly parallel coming out of the patient into the scintillator, they have to be, the collimators themselves diverge, and so a larger area of radiation or radioactivity can be detected, so it basically shrinks down things. Converging will be more of a zoom kind of look, and then the parallel holes have several different kinds. So if you want higher resolution, but lower sensitivity, you could have longer septa. If you want high sensitivity, so you want to pick up more photons, but you might get more noise, or some photons that are not exactly going parallel might be able to squeak through, but you'll have higher counts. You could have shorter septa, and also depending on the energy of radioisotope you intend to use, you can have thinner or thicker septa to help stop the radiation, because if you have really high radiation, it can go through thin septa and still cause noise in your image. And so there are different types of energy levels that the collimators are intended for. So to talk about pinhole collimators, basically what that does is it provides a high sensitivity, a zoomed image of a small area. So you have a small aperture, and what happens is the beam, the photons that come out of whatever you're imaging get reversed on the screen, and they get zoomed. And so you'll end up with an image that's upside down and reversed, so you have to flip it. Usually we'll use that. Most commonly what we use it for here at UNMC will be thyroid imaging. You can also use it for small body parts as well. So this is just an example here. I guess we also use it for parathyroids. This is a parathyroid scan here where you can see this is just the full field of view, regular straight hole collimator above, and then below that is the pinhole collimator, which is zooming in on the thyroid and parathyroid glands. So the initial and then the delayed image. And you can see on the full field of view, you just don't see that area quite as well, but then on the pinhole you can make out that there's a small parathyroid adenoma. So like we talked about, the multi-hole collimators can have either parallel, diverging, or converging, and the thicker the septa are, the higher energy gamma rays they will absorb. So depending on what you image, kind of like we said, you choose your collimator based on that. So a low energy collimator is going to be what you use most commonly, because our most common radioisotope is Tec-99m, and low energy would be up to about 150 kiloelectron volts. And then you have medium and high energy collimators. Medium basically would be for things like gallium or indium, and high energy would be for I-131. The longer the septa, the higher resolution you'll have, but you'll have a lower count rate. Basically because some of these that are not exactly parallel will still squeak through on a shorter septum, but you'll get more photons detected, which is what this image here is showing. Also, because the farther away you move from a radioactive source, the more the radiation is lost because of the inverse square law. You really want, in nuclear medicine, because you're using lower doses, you really want the detector to be as close to the patient as possible. That provides less opportunity for scatter and gives you better quality images. So here's just an example of when you put the detector immediately touching the patient versus if you have it 1 foot away. Just the level of quality of image you get. So you can have not all photons that reach the detector will be ones you actually want, and so that's called noise. And here are ways in which you can get noise. So you can have septal penetration. So occasionally, even if you have appropriately selected your septa, sometimes a photon will squeak through, and it will be thought that it's coming from the wrong place. Even you would think that the photon had to come from over here when really it came from over here if it goes through the septum. And then also, of course, you can have scatter events in the patient that then make it look like it comes from over here when really it came from over here. So a question: which of the following studies would utilize a medium energy collimator? You can pause it and think about it. All right, so we'll answer the question now, so hopefully you've paused it and thought about it. So we have, like we said, there are different energy collimators, and more or less the low energy will be your technetium. Your medium energy will be things like indium, and then your high energy would be like I-131. Also, I-123 is also low energy. So basically, Octria-scan, even though we didn't say that in the question, but it's good to know that uses indium-111, so that has kind of medium energy photons. Okay, so after the collimator, the next thing in your scintillation detector, in your gamma camera will be your crystal. So usually it's a thallium activated sodium iodide crystal for gamma cameras. So here basically the radioactive photon, or the gamma ray, will hit the scintillator crystal and convert that energy into light energy. And the conversion rate here is about 10%. And then this light is still relatively faint, so the next thing you have in the series is photomultiplier tubes, which are analog devices that amplify the signal from these light events to something that's more detectable. The crystal itself is very fragile, so you have to be careful with it, and it has to be sealed and kept away from moisture. And the amount of light produced is proportional to what the energy of the photon was. If you make a crystal thicker, then you'll have better conversion efficiency in terms of that gamma ray that comes in. It's more likely that it will turn into light within the crystal when it's thicker rather than going through it. However, then the light will scatter more within the crystal, and so you have lower spatial resolution. The next thing in the machine will be photomultiplier tubes. These basically they more or less amplify the signal from the light and help you all, and also give information on where the decay occurred. And they use just complicated analog electronics to make that work. That I don't think you necessarily have to know. After that, then they have pulse height analyzers that help, based on the energy level of whatever the decay was that was detected, they decide whether or not to include that in the image or whether it might just be scatter. And so what you do is you chose one photopeak or several photopeaks, which are to try to choose an energy that you're going to detect that fits with what your radioisotope is. So if you know you've got technetium-99m, if your window is a 140, then you might do that plus or minus 10%, which would be a 20% window. And like I said, you can have multiple imaging windows or multiple photopeak windows at once. So for example, indium-111 has several photopeaks. And so this is what that looks like in terms of the radiation that you detect, the energies. Your biggest peak will be where the energy of the gamma rays is, but then you'll also have lower energy X-ray or ray photons reaching the detector that are lower energy due to Compton scatter. And so you want to reject those rays that are due to scatter, and that's why you choose your window. So on the machine, you can control how long you want to get the image for, and usually what is chosen is the number of counts you want to get. So you can do either a certain amount of time, so you might image for a certain number of minutes, or you might image for a certain number of counts. And then how bright each count is made is just based on what you choose on the computer or on the machine. And this is just an example of how, if you want to even further eliminate scatter, so if you know your photopeak is here and you choose a window that's symmetric around it, you might be getting some scatter. However, if you choose a window that's actually a little bit higher or centered a little bit higher but still includes the peak, then you'll exclude some of that scatter. So what's a typical threshold number of counts for an average nuclear medicine study? So pause it here and think about the answer if you'd like. All right, so we'll move forward here. So 50,000 would be a normal number of counts for a typical nuclear medicine study like a bone scan. Okay, so gamma camera resolution. So if you want to be able to tell the difference between 2 points of tracer activity, that's basically the goal of resolution. And the way you measure that, or the way that's reported, is called full width at a half maximum. And so what you do is you take a point source and then you measure how wide that actually is on the machine at when it's half of the brightest spot. And I'll show you a graph of that here in a second. So the narrower that, the smaller that number is, the higher the resolution, because it's able to measure something that's smaller. And so state-of-the-art cameras basically have a resolution of 3 to 5 millimeters. So just to show you here, this is there's, if you graph out in terms of space what the number of counts you get from a point source, right where the point source is, you should have the highest number of counts, but then you'll have some counts that are a little bit to the left or right of that, and what you measure is the maximum, and then you measure half of the maximum, and you measure the width of that area, and that's called the full width at half maximum. So the smaller that size is, the better your resolution of your system is. So if you got like more problems with septal penetration, for example, that will get wider. Okay, so another concept here, dead time. Dead time is when two closely related events, so basically when a photon hits the scintillation crystal, it takes a little while for it to recover to be able to detect another event, and so that's called dead time. So if you have two photons hit the detector in quick succession, you may not be able to detect them both, or the machine might detect it as one high energy event rather than two lower energy events. And so that's especially important for things that either you use a high dose, and so you have a high count rate, or when you're doing dynamic studies that have poor spatial resolution, like GI bleed. Matrix size is another thing that can be manipulated on studies. So the larger the matrix you have, the better your resolution will be within the limits of the machine. But a smaller matrix takes less time to get, because you're going to have higher number of counts within a larger area. So a 32 by 32 matrix, in order to fill that up and have enough counts, it doesn't take you very long. However, that's going to have a lot lower resolution compared to a 256 by 256 matrix. If you want to have decent contrast on that, you're going to have to image for a longer period of time to fill up that that matrix, or to get decent data that's not too noisy. So basically, you choose your matrix size based on what your goals are. So if you're trying to have high temporal resolution and don't care about spatial resolution, then you can have a small matrix. And if you want to have good spatial resolution, but you don't really care about temporal resolution, like a bone scan, you can have a larger matrix. And then, of course, there's also a lot of processing and filtering and computer things that go on to make the pictures look nice. And here's just an example of what filtering would look like. So the initial noisy image you get out might look very noisy, and so if you graph the amount of brightness along this line, you can see it's kind of bumpy, and then you can smooth out that bumpiness, and then you get a smoother looking image. And we'll talk a little bit about that too when we talk about SPECT. Okay, so what is wrong with this bone scan, the posterior image over here? So something looks wrong, it doesn't look the same as this. So I'll let you look at the choices, think about what might be wrong, and we'll go on. You can pause it, and then we'll move on. Okay, so the issue here is that's off-peak. So this is a normal bone scan, and this is if you choose your image in that scatter range, you're still going to have stuff that looks hotter closer to where the bones are, but you're not actually getting the initial photon that's released from the bones. You're getting a scattered photon, so things just look a lot grainier and noisier. Okay, what's technically wrong in this image below? So I'll let you pause it. Okay, so if you look here, you can see that there's a round area here that does not have any signal, and that is actually caused by if you have a photomultiplier tube go out. And so the photomultiplier tubes are round and they're all stacked together, and so when you have one go out, you get basically a circular area that doesn't have any signal. What's wrong with this issue, with this image? I'll let you pause it. Okay, so you see this linear area of no signal. So rather than being the photomultiplier tube having a problem, this is a problem if the crystal gets a crack in it. So that's more of a, and that's all just based on the shape of what the artifact looks like. And then you can, of course, get other kinds of artifacts. So you can have barium in the GI tract, and that will block photons, and so you'll have an area of kind of white out there. And of course, you can have devices that are external to the patient, like pacemakers or necklaces, that also will block photons. So what causes this artifact right here on the right side of the body wall? I'll let you pause and think about it. Okay, so this person, here's their arm, and they've got a lot of uptake, and their body wall has a lot of uptake. When you have them lift up their arm, it goes away. And so that's actually extravasated tracer in the arm, and the radiation is going straight up to the crystal, and so that's correctly being registered. However, also some radiation is bouncing off the patient's body and then coming up to the crystal, and so it gets misregistered. So it looks like they have radioactivity on their arm and on their body wall, when really they only have it on their arm, and the rest of it's just bouncing off their body wall. Okay, so that's pretty much it for gamma cameras. We'll move on to SPECT and then PET. SPECT stands for Single Photon Emission Tomography. And basically that means, and you're doing tomography in a rotational direction, so you're going around the patient and making slices through the patient. And then positron emission tomography usually uses a fixed ring detector. Both of them are giving you 3D information and to allow for correction of artifacts related for overlapping structures and attenuation. And both of them pretty much use CT so that you can anatomically localize whatever is going on with your radio tracer. So SPECT, basically you're using a nicer version of a gamma camera, or it needs to be a little bit nicer version of a gamma camera that rotates around the person. And you can either rotate 360 or 180 degrees around the patient, depending on the kind of information you want. If you can technically do just 180 degrees, because the other side should just be the reverse of it. However, especially with gamma imaging, things that are farther away will be dimmer, and so it just kind of depends. If you don't really care what's on the other side of the patient too much, that's fine. But if you're wanting to get a true 3D image, then you'll rotate it a full 360 degrees. Also, some fancier cameras are able to do more elliptical rotations around the patient so that they can stay close to the patient at all times rather than circular. And also, fancier cameras will have multiple camera heads that rotate around the patient, or basically all of ours do. So here's just an example of what SPECT machines look like. So these machines, they can just rotate around the patient. You put the patient on here. And this is what calibration looks like. So they put a point radiation source here, and they rotate them around so they can find where the center is. And you can also either do the detectors 180 degrees or 90 degrees from each other, depending on the goals of your study. So if you're really interested just in one side of the body, say for example in a heart, you might just do that 90-degree orientation. Whereas if you want to do the, if you're interested in like the whole area of the body, like a speck of the bone or something, then you might do the 180 degree. So SPECT CT images have to be more complex than just regular planar cameras because they have to have better imaging properties, and they have to have additional components to account for them moving around and to not cause to not have issues with the detectors being out of alignment and that sort of thing. There are also cardiac SPECT CTs. There are specialized cardiac SPECT CTs that are available. So this, for example, over here is called a D-SPECT. So this one actually doesn't have any moving parts because really you're only interested in that area around the left side of the body. So more or less this is going to image that side of the body and just extrapolate the rest to make a SPECT image. And the nice thing with that is that you can use lower doses and less resolution if you're doing it just for that specialized purpose. Also, as you go through go around the circle of the patient, the camera will stop and take images at different angles, and the higher number of stops you do, the better resolution you'll have, but the longer it takes. And so usually 32 stops per 180 degrees would be pretty standard, but it kind of depends, of course, on your application. There's an issue with SPECT in terms of the farther something away from the camera, or the more stuff that's in between where the radiation occurred, or the decay occurred, and the camera, the more likely it is to be attenuated. And so things in the periphery of the patient will look brighter, and things in the middle of the patient will look darker, is basically what that leads to. And then also certain things that can move, for example, like breast, can also cause issues from one scan to the next, so comparing things. What a solution for that would be attenuation correction, which basically you can measure what the attenuation of the patient is, and things that are farther away from the detector, you basically crank up the brightness on those areas, whereas you crank it down where things are close to the detector. And you can create a map of what the attenuation of the patient is, and that's called an attenuation map. And that's a map of the mu values, is what the attenuation is measured in. So this is what an attenuation map looks like, is this middle image here. And they're basically really they're like a CT scan, but very, very bad. So you can do attenuation correction by rotating something radioactive around the patient. So, for example, gallium-153, you can rotate it around the patient with the gamma camera on the other side, and you can measure what the attenuation is from each angle, and you can correct that way. And it looks like a bad quality CT scan. However, that is very rarely done now, and almost everything uses CT instead for attenuation correction, which we'll talk about here in a little bit. So this is just a case. I'll let you look at this and see if you can think about what's going on. Okay, so if you look here, here's the stressed images and the rest images. Here, this kind of anterior septal wall has, it looks like a perfusion defect at stress, but not, or to a lesser extent, on rest. Also here, when we look at the stress and rest images, it looks like there's something here that is kind of blocking the imaging from the outside of the chest that's not really there on the rest images. And that is pretty typical breast attenuation artifact. And depending on the location of the patient, or the positioning of the patient from one scan to the next, this can really be variable. And so it's pretty typical to see breast attenuation artifact in the anterior lateral wall. And as long as everything else looks normal, you can suspect that something is breast attenuation artifact. And also then we use attenuation correction, which should fix that. So SPECT imaging takes a while, especially if you want better resolution. And so you really have to balance what kind of resolution you want versus how long the patient can lay still. And one of the ways you do that is what the matrix will be. So 64 by 64 versus 128 by 128 would be typical matrices. And just because you doubled the dimensions on either side doesn't mean you doubled how much information you need. Quadruple, because a 128 matrix has 4 64 by 64 matrices in it. So it takes a lot longer, or you're just going to have more noise if you use that higher, larger matrix. There's a number of ways to take that raw data of rotating the gamma cameras around the patient and turning that into a slice through the patient. And basically, it's complex math. There are a couple. The oldest, most complex, most common way to do that was filtered back projection, which also is used in CT. Basically, you take a bunch of lines through the patient, and you calculate what it would have taken to create the images you got. I don't know that I'm describing that well, but basically it's the simplest mathematically and the fastest way to create a reconstructive image, but it has a lot of problem with noise and artifacts. So this is examples of what the math would look like that I don't think you need to know. Now there are newer reconstruction algorithms. So iterative reconstruction, basically what it does is it cycles through the images and the data each time and continually improves the images until you meet some sort of threshold. But it takes, because you're continually cycling through the images a lot of times, and improving them on each iteration, that's what iterative reconstruction stands for, it takes a lot more computational power. And so so that's basically the trade-off, which basically has become less of an issue. So of course there are lots of names for iterative reconstruction like Acer or Veo and the iDose, things like that from different vendors. And of course Dr. Hansen did some research on iterative reconstruction. So. If you use filtered back projection, that filtered word means that a filter was applied to it. And what a filter is you are applying some sort of math to the image to try to remove the artifacts or remove noise. And the filters kind of, in general, you can group filters into things like high pass filters and low pass filters. And what that means is if it's a high pass filter, that means it lets high frequency stuff pass through. Or a low pass filter lets low frequency stuff pass through. And so a high pass filter would be a sharp image, but it'd be noisy, and a low pass filter would be smoother, but with less distinct, less sharp edges. And so you use different types of filters for different sorts of tasks. A lot of times Butterworth will be the most common filter, and that's what a Butterworth filter is shaped like. So this is the frequency in terms of how noisy the data is, or the higher frequency typically is noise. And so right here you're kind of cutting those things off, whereas you're keeping the lower frequency stuff. And you can shift that to the left or right depending on how much high frequency stuff you want to keep or leave away. And so there's different settings anyway. So these are the examples of different levels of Butterworth filter, in terms of this would be only letting really low frequency stuff come through, and this would be letting all high frequency stuff come through. And so your happy medium will be somewhere in the middle there. SPECT CT is something that you can do in addition to just regular SPECT, where you can use the CT both for attenuation correction and also for anatomic localization. And that's pretty much what everything is used with now. And usually the CT that's part of a SPECT CT is going to be a less expensive version of a CT scanner that you would use for diagnostic CT in your department. And a lot of times you'll just use the CT scanner in a low-dose diagnostic mode that is still good enough for attenuation correction, but it's not meant to be like high anatomic detail. Okay, here's a question. What artifact is going on this xenon ventilation scan? All right, so you look at this, it looks like the whole time there is radioactivity uptake. You can see a little bit in the lungs here anteriorly, but really there's just this smudgy uptake the whole time. So it seems like maybe they had some radiation before. So I think that there's a recently done bone scan, and that's what that is. So the bone scan is 140 keV. So all you're getting is the scatter from that when you're looking at the xenon 80 keV photo peak. And so this is the person's bone scan that was done right beforehand. All right, so PET. Basically, PET will always be done with CT, although technically you don't have to. So it's two scanners. There's a PET scanner and a CT scanner, and they're more or less, they're basically two separate machines fused into one. And so this is what that looks like. There's a ring detector that's used to detect the radiation from the positron annihilation events, and then there's also a CT scanner. So PET isotopes release positrons, and those will meet an electron. They will annihilate, and then they release two 511 keV photons that go in opposite directions of each other. And so the ring detector basically wants to see two photons of the correct energy arrive at the same time, and then it knows somewhere on that line between where those two detectors are, there was a decay event. And the speed at which those detectors are able to know when those occurred depends on the type of crystal involved and the type of scanner. So this is just a schematic of ideally how it would work. So you have a decay event occur here, and then the photons shoot off perpendicular to each other. In reality, though, the positron will travel a certain distance, and that depends on the energy of the positron, how far it'll travel. So different isotopes will have a different distance that will travel, but it's usually on the order of a few millimeters. And then also the angle is not exactly 180 degrees. It can be plus or minus a few degrees. So both of those things mean that your localization of where that decay occurred is just based on physics is not going to be perfect. And then in addition to that, you can have scatter occur, and then you would think that this decay occurred over here somewhere along this line because you detected something here and here, when really there was a scatter and event. So all of those things contribute just to noise in general in PET systems. So a PET detector works very similarly to a gamma camera. So they'll have a crystal, a photomultiplier tube, or a digital detector, and energy windows that are used to discard scatter. One thing that's different is that you may or may not have a collimator. So in older systems that were called 2D PETs, you did have a collimator. They had septa that made it so that only the photons that were going perpendicular to the collimators would get detected to reduce scatter. However, they've now gotten rid of that pretty much in all scanners, and so they don't really have collimators anymore, and they just use their electronics and the speed of the crystals to try to reject scatter, just because of the loss of data that you get when you use collimators. So that's called 3D PET when you don't have the collimators, and basically you just are looking for whenever there's a appropriately timed detection event, you use that. And so you have to have better electronics and faster crystals to be able to do that without having too much noise. So what happens is there's a photon released from the positron annihilation that hits the crystal, which creates light, and then goes to the photomultiplier tubes or the digital detectors, and then goes to the computer and makes an image. Different kinds of crystals have been used. Bismuth germanate would be the oldest, but it has the poor resolution. The lutetium-based crystals, so LSO and then LYSO, are kind of the newer ones that have better performance. Something that's done in PET that's not done in gamma cameras is they'll take the crystal and they'll cut thin little grooves into it. Because the photons are such high energy, you have to have relatively thick crystals. And so when you cut grooves like this, that helps the light not disperse too widely within the crystal. And so you can still localize where the decay occurred and have a thicker crystal. That's a way that they try to overcome that. Attenuation correction is also an issue for PET. It's really a bigger issue than for SPECT, and so you pretty much have to have a CT. On non-corrected PET images, things like the skin and the lungs will be very hot because those areas are either close to the detector or they don't attenuate very much. And so if you look here on the right, you can see there's on the right, there's a skin on this patient's very hot. The lungs are very hot here, so that's the non-attenuation corrected. But when you correct that, then the lungs actually don't have very much uptake, which makes sense. There's not much metabolic activity there. And the skin just has the same uptake as pretty much everywhere else. So the CT scan that's done with a PET CT happens pretty quickly relative to how long it takes to get the PET. And so you have issues with the patient moving in between the scans or during the scan, or just breathing. And so things like the diaphragm and the lungs, you can have misregistration. Also, if you have an area that's very high density on CT, that can lead you to overcorrect when you're doing your attenuation correction and make something look too hot on the PET. And that's a false hotspot. IV and oral contrast, theoretically, if that was not present, if that was present when you did the CT, but then it moves, that could cause artifact. However, most newer scanners, that does not cause artifact. And so IV and oral contrast are pretty much okay. And maximum PET CT resolution, based on those things we talked about, based on the positron moving and the angles of the positrons not being truly 180 degrees, and then just intrinsic limits within the machine. Basically, the best resolution you can get is somewhere between 6 and 10 millimeters. So if you have a tiny pulmonary nodule, you're not going to be able to really characterize it well with PET. One of the newer PET technologies, which our new scanner has, is time of flight PET, and also its digital PET. in that, so this uses a lanthanum bromide or a LYSO detector, which is again kind of a lutetium-based detector. These detectors are fast enough that not only can you say the decay occurred somewhere along the line between the two detectors, the detectors are fast enough that you can tell just slight differences in time of when they detected, and you can say, you know, it probably occurred whatever in the middle 10% of the line, or the, you know, you can figure out where along that line it was more likely to have occurred based on the slight differences in arrival time. And this really improves resolution, especially in large patients. So traditionally PET-CT does will kind of stop and shoot. So you'll image an area of the body, you'll move the patient a little bit, you'll image another area. Some scanners slowly move the patient through, kind of more like a helical CT does, rather than it's not a stop and shoot. Most of the time, the CT is done as a diagnostic quality mode, and it's done before the PET-CT. It's not uncommon to use IV and oral contrast, kind of like we said, and basically there's two types of PET in terms of billing purposes that you can get, which would be kind of skull to mid-thigh and then whole body. And generally for us, whole body would be when you're looking for things like infection or cancers that are likely to involve these extremities like melanomas or myelomas, and the other types would be more commonly just the skull to mid-thigh. PET MRI is a really great idea in that a lot of cancers are really best characterized with MRI, has really good tissue contrast, great spatial resolution, and if you could combine that with PET, it can really help you determine, you know, where tumor is and where it's not, and help plan for surgeries. And in places like the brain and liver, it should be really good. However, there are also issues in that being able to create PET scanners that are MRI compatible is expensive. The imaging of the lungs is also kind of hard. So, you know, a lot of cancers that you would want to be able to do a PET MRI with also have issues with lung metastases, so that can be a problem. So for those reasons, it's still not really used routinely for clinical care. It's mostly a research tool at this point. Okay, so here we have a PET-CT, and there is an artifact. So I'll let you pause it and think about it. Okay, so on these images, we see there's an area of uptake here. It looks like it's registering to the lower lung. When we look at the lower lung, at least on the image here, we don't see anything. But when we look in the liver, we see a mass. And at that area on the PET, there's nothing. And so this is a misregistration artifact. So what happened is, you know, when the patient took their CT, or when they did their CT, they maybe took in a deeper breath and their diaphragm moved down. And so the liver looks like it's lower than it is on the CT, because then when they do the PET, they're just breathing quietly, and so the metastasis moves up. And so PET quantification, so it's nice to be able to measure how hot things are on PET. It helps you kind of determine from scan to scan, are things getting better or worse the same. However, there are problems with it in that there's a lot of variability from scan to scan in what people's metabolic activity is in general and things like that. So SUV is something that we measure, which I'll talk about a little bit more, how that's calculated. And then there are also a number of reporting systems that you can use to try to describe whether things are responding or not on PET. In general, in clinical practice, usually you measure the maximum SUV of whatever area you're worried about, the tumor, and then you also report the liver and blood pool background as kind of relative comparisons. So SUV, what SUV is essentially it's a ratio of what the number of decays that you're measuring in a certain volume on the patient. So it's how much you're measuring versus how much you would expect to measure if the patient was just a big bag of water. So if the patient was a big bag of water and you injected a certain amount of radiotracer into it and then let it diffuse everywhere and then also account for how much it decays, that everywhere you measure that, your SUV would be 1 in that it should uniformly have the same amount of radiation everywhere, and it would be exactly as you would expect it to be. But a patient doesn't work like that, so certain areas like the fat, the subcutaneous fat, and the lungs will have a lot less radiotracer relative to other parts that will have higher uptake, like the liver or the kidneys. And so your SUV, that ratio of what you measure versus what you would have expected to measure, will be more than 1 in those areas that have higher, and it'll be less than 1 in those areas that have less, like the subQ fat. And this is important to understand in that, so it accounts for the size of the patient, and it also accounts for the amount of radiotracer injected, and it accounts for the decay time, but it does not account for anything else. So if a patient is a large size, it doesn't account for whether that's all fat or whether that's muscle. So muscle has a typical SUV of pretty close to 1, so a really heavy but muscular patient, you wouldn't expect that their SUVs would really be affected. But a patient that has a lot of subQ fat, again, if you think you're expecting that they've got this large volume that the radiotracer should have been distributed in, but all that fat is not taking up. So you get artifactually increased SUVs in the normal organs because you're thinking that all this tracer would have been, you're overcompensating basically for the size of them when really the fat's not having uptake. So basically that's what all that says. And with any area that you measure, you can report the mean SUV or the maximum. Like we said, maximum is usually what you're going to report. And a whole bunch of different tissues have general amounts of SUV, which is amounts of uptake, which is kind of within normal limits. So things like brain or heart will usually have variable or high uptake. Kidneys, things that also might have uptake would be things like liver, blood, testicles, submandibular glands, and then there's a whole bunch of other things. So you can look this sort of table up pretty easily. So SUV, we talked about the weight thing. Also, things that are not included in SUV but can affect the amount of uptake within tumor or within physiologic organs would be things like serum glucose, which we do measure, so you can kind of mentally be aware if they had a really high glucose, maybe their SUVs will be lower than normal, but also how much insulin they have on board, that affects their glucose metabolism and will affect the distribution of the tracer, and so that you can't really measure. We have them fast to try to keep the amount of endogenous insulin low, or if they're diabetic, we try to have them not take their their insulin, but really you can't measure it. So those sorts of things are not accounted for by SUV, and so that's what makes SUV a semi-quantitative thing and not quantitative, and that's why basically interpretation is done on a visual basis. You really want to have like a 25% change in amount of SUV to really be sure that this is a true change, and it's also pretty unreliable for smaller things. Okay, so looking here, what kind of artifact do you think is going on? I'll let you pause and think about it. So looking here, it looks like there's a hot spot in their spine, and when you look at their spine, there is an area of vertebroplasty. So I would be worried that this is some sort of overcorrection. This area is very dense on the CT, and so maybe it cranked up the brightness in that area, thinking it was all getting attenuated and overcorrected. And so this would be a falsely elevated SUV. And there we are, and you can confirm that by looking at the attenuation corrected images, and if you look at the non-attenuation corrected, that area is not really a problem. So that's overcorrected. And that is it. Thank you very much for listening in. I hope it was helpful.